Okay, students, now I'm going to cover normal physiological adaptations in postpartum. Once the baby is delivered, within 24 hours, mom will start peeing like a racehorse, I call it. So she should be putting out urine. If you look at the policy and procedure, at that point as well, you want to measure the first urine void. So that first urine void, according to policy, should be at least 250 cc's or more and documented to know that mom, yes, is putting out, and therefore that also shows us there's no damage to the bladder. Decreased blood volume, of course you're going to have that. She just had a baby. And increased hematocrit, her vital signs should return to the pre-pregnancy state. In other words, she may have had high blood pressure throughout this pregnancy, and we were monitoring it closely. But once she's delivered, and that's the cure for high blood pressure, is delivery of the infant, you should see the blood pressure go back to her pre-pregnancy parameters. Receding varicosities, of course, remember that there was a 50% increase in blood volume, so that is no longer the case. So varicosities, remember, are can be in the legs and also in the vaginal area. I have often seen it. So these are normal expectations that you'll see after delivery. So reproductive. So uterine involution. Involution, it takes 6 to 8 weeks for the uterus to go back to its pre-pregnancy state, and each day should be one finger breadth below the umbilicus. So we're going to be checking that if this is your patient. It's expected the patient will have cervical and vaginal contractions. That's expected, as I said. However, the more pregnancies the patient has, the more she's going to be uncomfortable and have more contractions. And these are not like the contractions that to push the baby out. However, they can interfere with what she needs to do on a daily basis. So what you want to think about is getting her something for pain meds. Yes, she will continue to have a discharge, and we'll talk about that discharge as well. And you can tell her that. We want to look at her pelvic vaginal area. If you're the assigned nurse, it's your job to know when you received this patient, what did it look like, and then when you change shifts, was it still the same? So you have looked at her vagina, and you know whether there was any hematomas, bruises, swelling, edema, and that would have been documented. So is she breastfeeding? We want to know that. Yes, her hormones are going to be all wacky. And so we want to inform and educate her on what the expectations are after delivery. And also get her to think about what would her life be like um, for the days and weeks following the birth of a baby. Maybe it's her first baby, maybe it's not. Can she juggle more than one, or can she juggle more than five? Those are things that are questions that to ask the patient. What are your plans? Are you going back to work? Things like that. So rooming in, back when I first started practicing in '85, we did not do rooming in with moms actually. All the babies went to the nursery and they didn't go to mom's until it was time to feed. But now the policy is to keep the infant with the mother as much as possible. Typically, the baby does not go to the nursery, even for assessments, because we can do that at the bedside. Sorry, you hear the lambs in the background. We can do that at the bedside. And baby would only go to nursery if there were any complications and we want to inspect this infant further, and or baby needs to be under warmer because it's too cold. So siblings, make sure that siblings wash their hands if they do are present. And also, if mom is having siblings hold the baby, that the child is sitting down and has a good hold on the infant. Postpartum care. So we already talked about uterine involution. Fundal position. The fundus should go decrease 1 finger breath for every day postpartum, and you'll learn that in lab and how to check that. Boggy. So when we check the fundus, which is the top of the uterus, the house the baby lived in, we want to make sure that it's hard and firm. It feels like a grapefruit in there, so we can massage it till it gets hard and firm. But sometimes it's not. When it's hard and firm, that means the muscles are contracting and she's bleeding less. But if it's soft and boggy, just the opposite, then she could be hemorrhaging or bleeding out. And some of the things, if she's boggy, it could mean that she has some retained placenta. So you also want to look at the lochia. That's what the discharge is called after delivery. The lochia. It starts out with rubra, serosa, alba, and so we will cover that when we go to lab. Cervical changes, sure. The cervix never really goes back to what it was like before there was never anything out the outdoor, but it should go back to like at least a very small opening. Vaginal changes decrease. If there's any bruising, there should no longer be bruising. If stitches were present, then they should be healed. So we look at that 6 weeks postpartum checkup. The provider looks to see that everything has gone back to that pre-pregnancy state. So we want to encourage mom to keep that appointment. Okay. Of course, ovulation and menstruation will return. It might take longer if mom is breastfeeding. However, it should return. Lactation, that's breastfeeding the infant. If mom is breastfeeding, you want her to wear a good support bra, and it usually takes 2 to 3 days for the milk to come in. But the important part is that she puts the infant to breast every 2 to 3 hours around the clock. Okay, GI system. Yep, everything. She should be able to tolerate and eat a regular diet. If she had a vaginal delivery, a C-section, we encourage her to take sips and increase slowly her intake. Urinary tract, as I had said before, she should be putting out urine, peeing like a racehorse. So we want to check that. We want to verify, yes, she is voiding, because the bladder can be damaged in labor, whether it's a vaginal birth or a cesarean. With a vaginal birth, if she has a full bladder and pushes the baby back over that, it can become bruised. And if she has a cesarean, they can actually nick the bladder. So we want to make sure she's putting out. Vital signs should return to normal. Of course, there'll be a weight loss. She lost that pounds of baby and other products. So postpartum chills, that's like an expected part of after delivery, since everything, all the hormones are adjusting at this point, and the adrenaline from delivery. I usually just get mom a warm blanket and say that's expected. And postpartum diaphoresis is another expectation, only because of all the process of changes during the delivery. So uterine involution, yes, it returns to its pre-pregnancy state. But if it doesn't return, it could be some because by an infection as well as some retained placenta in there, it's important that we check mom after delivery. It's frequently. Um, it takes about it takes time for that placental site to heal. So if you think of it like this, the placenta was attached to the uterine wall, and once it's delivered and detached, it's like an open sore inside. So it can brew infection, and there can be complications from that. So, and it does take a while for that to heal. You'll see a slight increase in the white blood cell count only because it's healing. It's the body's process of healing. So you can see this explains after the uterus how much what you would expect after delivery. Okay. After birth, as I'd already said, the first day it's 1 finger breath below, and second day would be two, and so forth. You would expect it to decrease where it's located, the fundus is located. If it's not, then we have a complication. So when it becomes boggy or uterine atony, that's the correct terminology to use, atony, is where the uterus is soft. So one of the things that we have to do is we have to massage it because if it's soft, she's bleeding out. So we want it to be hard and firm, not soft. That's the reason for checking and documenting that. So uterine contractions, yes, it's expected after delivery. What do contractions do? Well, it prevents bleeding. Okay, yes, it gives her cramps. And as I had already said, it's common to have more cramps and stronger cramps if it's not her first baby and the more babies that she has. So think about pain meds. Usually it's ibuprofen that we want to give for pain meds. All moms receive oxytocin after delivery as part of the policy. If she came in quickly and delivered and didn't have an IV, we could give it IM. So that's what that does. What does oxytocin do? It causes the uterine contraction so she doesn't bleed out. So typically, if she has an IV, she would be given oxytocin IV. If she doesn't, then we could give it to her IM. Breastfeeding mothers. Well, milk doesn't come in to 2 to 3 days after, but baby has or mom has that colostrum, which is what I call the liquid gold. It's got all the immune antibodies in that baby can receive. And baby's stomach is only the size of a marble, so all it needs is maybe 3, 4 sucks, and it's got a full belly. Even often moms don't realize that. And the milk does not actually come in to 2 to 3 days, but we want to put the baby to breast every 2 to 3 hours so that it will encourage milk to come in. And that's around the clock. I always get concerned when they say, oh, baby slept all night. Well, that's not a good thing. Okay, so this is about the rubra, which is the discharge after delivery, which is dark red in color, first 2 to 3 postpartum days. Sometimes you see a few small clots, and take note of that. Um, but this is something that you need to educate mom on because she's going to be going home within 48 hours of delivery. So she might still have the rubra when she's discharged. It's no, she should know what to expect. Then the serosa, and then the alba. So it talks about how long that should. So this is, see my little man there, tells you be aware of that. The cervix, it changes as well. Obviously, is what I had said. Once something goes out that outdoor, then it's never the same. Vaginal, it might be edematous and bruised. Make sure if you're the nurse assigned to the patient, you received your handoff about the patient. Your job is to assess and evaluate what does that vagina look like now? What does the perineum look like now? Because she could have um, have a hematoma, the swelling could be worse, the bruising could be really bad. But when the nurse that handed her off to you said, "Oh, her vaginal area is fine. It's no big deal." But then when you go to look at her, she's got bruises and she has edema, so she may need ice to keep an eye on that. So episiotomies are not something that's done routinely. Back in the 80s, we did that. Every mom that came in, first time baby, she received an episiotomy. And what is an episiotomy? It's a standard cut that makes the vaginal opening larger. We don't do those anymore. It's actually better to just allow the vagina to tear, because it doesn't tear any more than it needs to. It could be a small tear, where episiotomies are pretty standard and pretty large. Okay, so we make sure that you're looking at the vagina. That's part of what we do in maternity. Okay, if she has delivered um, vaginally, usually mom can start right away on a regular diet. You often see them bringing in, "Oh yes, we're going to McDonald's or Burger King." Not especially good, but I guess they are if you're really hungry. If mom had a large tear, she may need to make sure that she drinks more fluids, and she may need something for pain and a stool softener. And be aware of exactly her diet. That she eats more roughage. Okay, so all of those things that we talked about before, the skin changes, the diastasis recti, the butterfly on the face, all of that stuff kind of disappears within 6 weeks. It should. It goes away. So these are just some cultural things you might want to think about, especially in our melting pot of the U.S. There are so many different cultures here, and as a nurse, you're going to see a lot of different people. So just to have some knowledge is good about your patient, what their needs are, and how they're met. So nursing assessment, we want to look at mom's history. When I say postpartum nursing assessment, um, in her history, because maybe this wasn't her first baby and she had a history of hemorrhage, or she had a C-section previously. We want to look at her laboratory data. She came in with a low H&H. She had a large amount of bleeding, so be aware what maybe that H&H is now, since she already delivered. And any other issues psychologically. Was she on pain, or not pain, sorry. Was she on medications previously and had to be taken off them, maybe for depression? And now that she's no longer pregnant, are we able to put her back on those? So that's something you want to be aware of, and inform the provider about as well. These are some diagnoses you may end up using. And of course, interventions that we will be using as well. And psychological well-being. In other words, parent-infant attachment. Is this mom holding the baby? Is she participating in care? Is she changing the baby? Breastfeeding on a regular basis, or bottle feeding, whatever it may be. Maybe she's not. After all, we had one case where she didn't want the kid, but he did. So he was doing all the, and that's what the mom said. He was doing all the care for the baby, and so what do we do with that? What do we do if we find that there's an issue? We usually call or document it, if there's a problem, and maybe talk to the patient about it, and also have the social services, or I forgot what they call it, anyway, social services look into it as well. So we want to do a follow-up appointment to have some other person evaluate the situation to make sure this baby is safe to go home with his parents. Okay. So if you have any questions here, make sure you write them down so when we meet virtually, you can ask me. Thank you.